Everyone, we're going to talk about kind of some stroke updates. So for just a reminder, our stroke goals, our door to activation time is less than 10 minutes. Door to CT is less than 15. Door to needle or door to TNK is less than 30. And then door to device or door to thrombectomy is less than 90 minutes. We've done really well with all those. The one we're kind of working on right now still is that door to device time. It just takes a long time sometimes to get the team rounded up and get a patient down there. So just a reminder, if they're going to interventional radiology, make sure you get them undressed, similar like you would with a cath lab patient. And then at nighttime, when that team has to come in from home, it's been super helpful to have our team just run the patient down to the OR suite when the team gets there. The next thing we have to talk about is BFAST. Everyone that works for Intermountain has to be educated on BFAST. So we're pretty familiar with it in the ER, but just a quick reminder, the BFAST stands for balance, eyes, face, arms, speech, and time. So balance, so if anyone has a positive BFAST, we're worried about stroke. So any problems with coordination or gait. For balance, any issues with vision for eyes, any abnormalities with facial movement for face, and then any drift or weakness in the arms, then any issues with their speech, if it's slurred, garbled, or inappropriate. And then time in the hospital setting is we need to determine and document a last known well. Something to be aware of, Mesquite EMS is utilizing this new RACE, Rapid Arterial Occlusion Evaluation Scale. So you might hear them report this when they call and give reports on stroke patients. To me, it's kind of similar to a BFAST. And if you look here, they see facial palsy, arm motor function, leg, head gaze, aphasia. So if you see down at the bottom, any score above a 0 is a stroke alert. So they're utilizing this in the field to alert or to call their stroke alerts. NPO, we're still having a lot of issues with our code activations and TIAs, getting medications in the ER and not having a swallow screen. So just a reminder, all code stroke activations and TIAs, we need to keep NPO in the ER unless there's extenuating circumstances. A lot of medications they're ordering, like Plavix and aspirin, aren't needed until sometimes hospital day 2. So those are not acute needs that we need to address in the ER. So if your provider orders them, maybe remind them, see if it's something they really do need at this time. Otherwise, keep them NPO. We have the stickers in the hallway where the stroke bed is. You can put it on your patient to remind you. And then if you do need to do a swallow screen, just a reminder of where to find that. It's in the stroke narrator in Epic. So if you go up here to the narrators, stroke, you'll see down here the Yell Swallow screen. So right off the bat, you have to answer this first question. So if they have any of these, those are all contraindications. And so this is when we would stop it. We would not continue with the swallow study, and they would not be able to have anything by mouth. So if they have no contraindications, you can hit continue, and then it will, the workflow will launch that shows you all the rest of the questions. So, what's their name? Where are you right now? What year is it? Labial closure, are they able to close their lips? Lingual range of motion, are they able to move their tongue around? And then facial symmetry. So if they answer incorrectly or a no to any of these, they fail. We can't continue with the swallow study. Then you have them swallow the 90 mils of water, and then you answer the pass or fail question here. If they pass, you can give them something by mouth. If they fail, they need to be NPO, and they will have their swallow study done on the floor with a speech pathologist. The last thing we need to talk about is enhanced neurocheck. So again, they are in the stroke narrator, and so it's pretty neatly laid out. Enhanced neurocheck, you can answer all the questions here. The only thing I wouldn't worry about is this NPI has been retired, so we do not need to answer that question there. And then again, those need to be after TNK patients. We need to make sure that we are doing those every 15 minutes, and that's for 2 hours. So generally, by that time, they make it to the ICU. When they move to the queue, 30 minutes. Otherwise, on your other patients that are not TNK, we're just doing them as ordered by the provider. That's all I got. Reach out with questions. Thank you.